In the previous section, we have discussed extensively on the pharmacology of the antitubercular drugs, but in this particular section, we are going to deal with the actual guidelines of how to treat, because there has been a drastic, in fact, a very big change and a very big paradigm shift from the previous guidelines, which was formulated in 2012 and the National Strategic Plan 2017. And I'm going to list out the changes that have been done in a few moments. But first, before going into all those things, we have to know the ever important case definitions first of tuberculosis. So what are going to be the case definitions and what are the changes from the previous guidelines? Actually, the definitions as such has not changed, but the names have been changed from the previous guidelines and the treatment has been changed. So let us first see what the new guidelines are telling and what is the name that was given to the old guidelines. So what do you mean by a new case? Definition of a new case doesn't change much with the previous as well as the current guidelines. A new case is the one who has not been exposed to antitubercular drugs in the past, any form of ATT treatment, antitubercular drugs in the past, or who have exposed to antitubercular drugs in the past, but for less than a month. So this is what we call it as a new case. And this is the same in the old guidelines also. There is not much change in the new guidelines. And second one, we have a category called previously treated cases. A previously treated case, very simple definition, those who have been exposed to antitubercular drugs or those who have been treated with antitubercular drugs for more than or equal to 1 month in the past. So this is what we refer to as a previously treated case, and there is no difference from the previous guideline as well. But under the previously treated case, we have some sub-classifications and subcategories. Like the first one, we have something called a recurrent TB case. Previously, this recurrent TB case was called as a relapse, but the name only has been changed now to recurrent TB case, but the definition as such has not changed. So what is the definition? So previously exposed to antitubercular drugs for more than a month, yes, plus they have been declared cure, or treated completely, treatment is successful, but now coming again with the microbiologically confirmed tuberculosis. So this is what we previously called as a relapse. Currently, we are going to call it as a recurrent TB case. That's all. Then we have treatment after failure. Previously, this was simply called as a failure case. That's all. Clear? So which means it's very simple. The idea is failure treatment. They have been exposed to ATD, antitubercular drugs, for more than 1 month, but still their TB is not getting cured. So it's a failed treatment. So this previously was called as a failure. Now we are going to call it as a treatment after failure. Now next thing, we have something called treatment after loss to follow-up. Loss to follow-up. This is the third definition we need to know, subcategory under the previously treated cases. Previously, this was called as treatment after default or defaulted case, but currently we are going to call it as treatment after loss to follow-up, which means they are exposed. There was a history of exposure to antitubercular drugs or treatment with antitubercular drugs for more than a month, all right, but subsequently they have been lost to follow-up, and now they are presenting again with microbiologically confirmed tuberculosis case. Clear? So this is what we called as a defaulter previously. Now we are going to call it as a treatment after loss to follow-up. These are some modified names, but actual definitions remain the same. The treatment has a drastic change. Yes, this new case currently is going to be treated with 2 HRZT plus 4 HR and E. You can see the total duration of the treatment will be 6 months here, right? All right. Now we have this previously treated cases, which is going to be treated with 2 HRZTS plus 1 HRZT plus 5 HRE, which means you can clearly see the previously treated cases will be treated for a maximum of 8 months. The total duration of treatment in previously treated cases will be 8 months. And there is no change. Even the old guidelines, the new cases will be treated for 6 months, and the previously treated case will be treated for 8 months. So what is the big difference here? Even though you can see the duration of treatment is the same in the old and new guidelines, but there is one major change, especially for category 1. So this is what we referred previously as category 1, and this is what we referred the previously treated cases we called as category 2. But what is the major difference? Previously we know that it's treated with 2 HR ZT plus 4 HR, and here we are going to treat with 2 HR ZT S plus 1 HR ZT and 5 HRE. What you are seeing here is the previously treated cases, that is category 2, has no change. The same thing we are following in the new guidelines also. But one big breakthrough change is the fact that you don't have ethambutol in the continuation phase of category 1. That is a new case. But here we are going to use ethambutol in the category 1 treatment. That is for new case in the continuation phase also. That is a big difference. Apart from that, category 2 treatment is the same. There is no much major change, but in category 1 treatment, that is a new case treatment, compared to the previous guidelines, we have added ethambutol in the continuation phase also. That's a big change. Yeah. Then what is the duration? Can you extend intensive phase or continuation phase? Yes, in the previous guidelines, yes, there was some room for extending the intensive phase, but currently in the new guidelines, there is no room for extending the intensive phase. Intensive phase remains the standard. But you can extend continuation phase by 3 to 6 months in some special scenarios. What are the areas where you can extend the intensive phase by 3 to 6 months? Number 1, in your tuberculous meningitis, clear, or any other form of CNS tuberculosis like tuberculoma. So I can simply write as in CNS tuberculosis, I can extend the continuation phase by 3 to 6 months, depending on the clinical and microbiological response. Second, in skeletal tuberculosis, like for example, you have a TB osteomyelitis or vertebral column TB, like your port spine, in those conditions also you can extend the continuation phase by 3 to 6 months. And finally, you can extend the continuation phase by 3 to 6 months in case of a disseminated, that is a miliary tuberculosis. In these conditions also you can extend the continuation phase by 3 to 6 months. But as per the guidelines, there is no need to extend the continuation phase in certain other extrapulmonary tuberculosis like gastrointestinal tuberculosis and lymph node tuberculosis, that is TB lymphadenitis. In these conditions, as per the guidelines, you need not extend the continuation phase by 3 to 6 months. Still, you can use the same 6 months or 8 months regime as per the new case and old case or previously treated case definitions. That's it. So this is something very important to know. And next, is there any indication for steroids in tuberculosis treatment? According to the old guidelines and the new guidelines, yes, you have indication. The best indication for steroids in tuberculous meningitis. Clear? In tuberculoma, limited benefit, but tuberculous meningitis definitely yes. The maximum benefit is steroids. You're going to get with tuberculous meningitis only, and you can give steroids up to 4 weeks. Standard, we follow prednisolone or dexamethasone. You can give them for at least 4 weeks, in fact. Clear? Next, you have some good body of evidence for use of steroids in pericardial tuberculosis like constrictive pericarditis also. But again, this needs further confirmation, but right now we have a good evidence for these two. But the maximum evidence is for tuberculous meningitis only. But one thing is controversial, that is pleural tuberculosis. Absolutely controversial. Even now, in exams, you please answer you don't use. In pleural tuberculosis, we don't use steroids as of now. Very, very controversial topic. Just close it down by writing you don't have any use of steroids in pleural TB. That's it. So these are the two classic indications for using a steroid. Don't forget the TB meningitis. Fine. Now I'm going to summarize what are the differences you made between the old guidelines and the new guidelines. So let us write the new guideline here and write the old guideline here. These are the major breakthrough changes that have been happened in the new guideline. In the old guideline, we know it's intermittent regime. Currently, in the new guideline, there is no role for intermittent regime, and we have adopted the Western and WHO standards by following the daily regime. It's universal daily regime, and nowhere in the country now intermittent regimen is allowed. You have to follow the daily regime only. And then you know that ethambutol we used in continuation phase only for category 2 patients, which means previously treated cases. But here we are using ethambutol in continuation phase in both category 1 as well as 2 patients, which means we don't call category 1, 2. Just for understanding, I'm telling this is new case and this is previous treated cases. So in both new as well as previous treated cases, we are going to use ethambutol in the current regime. Clear? So now previously we didn't follow any fixed dose combinations. Whenever I write FDC, it means fixed dose combinations. We are not going to use, we have not used any FDCs in the previous regime, but currently the norm is FDCs only, fixed dose combination pills. I'll tell you what is it in some time. Previously we had very limited weight bands. Currently we have a lot of improved weight bands. A lot of weight bands have been described in the current guideline, which I'll tell you again in a certain moment. Now previously there was a room for intensive phase extension. Clear? When they did intensive phase extension, the previous guideline, at the end of intensive phase, if the patient is still sputum positive, which means smear positive, those cases we have actually extended the intensive phase by 1 month. If the smear is positive at the end of the intensive phase, we extended the intensive phase by 1 more month. But I told you smear as well as your rapid molecular testing like GeneXpert cannot differentiate between live and the dead bacillus, which means at the end of intensive phase, you might be actually encountering a bacteria that is dead, which you might be falsely thinking that it is a living bacillus by smear or GeneXpert, and you might unnecessarily be exposing these drugs, exposing these patients to toxic effects of this antitubercular drug. So the current idea is no need to extend the intensive phase at all, at any cost. You just give 2 months of intensive phase in case of category 1 or 3 months of intensive phase in case of category 2. That's it. So there is no need to extend intensive phase at all. Clear? Finish. Then how will you follow up the case? Previously we followed up the case by only laboratory methods, that is microbiological, but currently follow-up is both clinical as well as laboratory. I'll explain you again when I'm going to discuss the guidelines. And again here, no long-term follow-up was done in the old guidelines, but clearly now long-term follow-up is done according to the new guidelines, where we do approximately at least for 2 years, even after completion of the treatment. Clear? So these are some of the drastic changes that have been incorporated in the new guidelines in the NSP, National Strategic Plan 2017 to 2025. Clear? So now let us move on to our FDCs, dosages in tuberculosis. What are the traditional dosages? And this dosage is what is followed in the Western guidelines. These are called limited weight bands, and where you know the famous drugs HR, Z, E, and S. Let us see what are the standard doses. It is 5 milligram per kilogram. Rifampicin is 10 milligram per kilogram, and pyrazinamide is approximately 25 milligram per kilogram, and ethambutol is 15 milligram per kilogram, and streptomycin again 15 milligram per kilogram. And let me tell you the maximum doses that has to be given per day. The maximum dose that can be given per day is 300 milligram. This is the maximum for isoniazid. And the maximum dose you can give in the daily regime for rifampicin is 600 milligram per day. This is the maximum you can do per day for a daily regime. Again, for a daily regime, maximum dose of pyrazinamide you can give is approximately 2 grams per day, that is 2000 milligram per day. And the maximum dose of ethambutol that you can give as per the daily regime per day in a day is approximately 1.6 grams. This is the maximum dose of ethambutol you can reach. And streptomycin maximum dose you can reach is approximately 1 gram per day. So this is the maximum dose you can reach with streptomycin in a daily regime. We are talking about the daily regimes because there is no longer your intermittent regime is going to be useful. This is a traditional dosing limit. But currently we are going to follow FDCs, that is fixed dose regime. So what do you mean by fixed dose regime? Because we are going to have a tablet that's going to contain a fixed dose combination in adults as well as in children. Let us see first in adults, what are the FDCs that are followed. Remember, for the intensive phase, you know you are going to give HR, Z, and E, and this HR, Z, and E is going to have a fixed combination, like H will be 75 milligram in a particular tablet, and R will be 150 milligram rifampicin in a particular FDC tablet, and Z will be approximately 400 milligram in a particular FDC tablet. And finally, your ethambutol will be having 275 milligram in a particular FDC tablet. Similarly, in the continuation phase, you are going to use HRE tablets, and this is going to have almost the same, that rifampicin, isoniazid 75 milligram, then rifampicin 150 milligram, and ethambutol 275 milligram. This is a fixed dose combination, which means this tablet, a single tablet, is going to contain this amount of the drug. It's a fixed dose. There is no change. The tablets are not going to be different in any way. All the tablets that is given in a strip will have the same number of dosages, same amount of drug in each and every tablet. Only the number of tablets may change depending on the weight bands. So how we are going to change? Depending on the weight category, that's why I told improved weight bands here. If the patient is in the range of 25 to 39 kilogram only, we are going to give 2 tablets in the intensive phase and 2 tablets in the continuation phase. If the patient is having a weight of 40 to 54 kilogram, I'm going to 3 tablets in the intensive phase and 3 tablets in the continuation phase. If the patient is having 55 to 69 kilogram, then I'm going to give 4 tablets each in the intensive phase and continuation phase. If it's more than or equal to 70 kilogram, then we'll be giving 5 tablets in the intensive phase and 5 tablets in the continuation phase. So this is what we refer to as fixed dose combination. It avoids the confusion to the patient, because if you change the different tablets at different dosages, for example, sometimes you might be giving, if you calculate by this traditional weight, you might be giving separate isoniazid tablet at 300 milligram, rifampicin tablet at 600 milligram, all right, and this will come as a combination. And you will be taking pyrazinamide tablet separately. You have to give 1500 milligrams, so you'll be giving 750 into 2 tablets. And separately, ethambutol has to be given at 1200 milligram, which will be separately giving as 800 plus 400 2 tablets. So this is very confusing for the patient, giving 2 750 milligram, 800 plus 400 ethambutol if you need 1300, and separately isoniazid and rifampicin. So quite confusing. So complaints may be reduced and the patient may be taking a wrong dose. To avoid all those things, once you introduce this FDC, you just have to tell this particular tablet, take this strip, eat 2 tablets, that's it. Or eat 5 tablets, or eat 4 tablets, that's it. Over. So it's very easy for the patient to understand, and the errors in the dosing also will be very, very less. That's why currently we are using this FDC kind of formulation, this fixed dose combination. Suppose in case if you are using streptomycin, clearly we'll use streptomycin only in category 2, that is currently we call previously treated cases. So here streptomycin dose will be 0.5 gram, that is 500 milligram. In this band it will be 0.75 milligram. If you're using 4 tablets it will be 1 gram, and if you're using 5 tablets again will be 1 gram, because I clearly told you maximum dose of streptomycin that you can use is only 1 gram per day, because we are using the daily regime now, not intermittent regime at any cost. Suppose the only exception for this rule is, suppose if the patient is age more than 50 years. Only exception for this streptomycin rule is the patient is having age more than 50, then again the maximum streptomycin dose you can use is 0.75 gram, irrespective of the weight. Whatever higher the weight is, doesn't matter, the maximum streptomycin dose will be 0.75 gram only in patients who are age more than 50, compared to the patients who are, other patients who are age less than 50, where the maximum dose of streptomycin will be 1 gram per day. So this is the only exception. Age more than 50, maximum dose you can use is only 0.75 grams per day. In children also, we are using FDCs only, but little different, because we are going to use different tablets. In intensive phase, we'll be using HR, Z tablet separately and E tablet separately. In continuation phase, we'll be using HR and E tablets. Children will have a different dosage, that is a lesser dosage in the FDC tablet. For example, for H, they will be having 50 milligram instead of 75 milligram in adult tablet. For R, they might be having 75 milligram instead of 150 milligram that we had in the adult tablet. And similarly, Z, they are going to have 150 milligram instead of 400 milligram in the adult tablet. Similarly, this ethambutol, it's going to be 100 milligram. It's a separate tablet instead of the 275 milligram in the adult tablet. Clear? Simple. Same thing here. H is going to be 50 milligram. R is going to be 75 milligram, and ethambutol is going to be 100 milligram. Based on children's capabilities, they have reduced the amount of drug in the FDC tablet, but still it remains the FDC. It is the fixed dose combination. So what you're going to use here, if the child is only 4 to 7 kilogram of weight, you are going to use only 1 tablet each in intensive phase as well as in the continuation phase. The child is 8 to 11 kilogram, you're going to use 2 tablets in all these categories. If the child is 12 to 15 kilogram in weight, you are going to use 3 tablets in all the category during the intensive phase as well as the continuation phase. The child is somewhere between 16 to 24 kilogram, you are going to use 4 tablets in each category. But little complicated from now on. If the child is 25 to 29 kilogram, you are going to use 3 tablets, all right. But stay with me, you are going to use 1 adult tablet at each phase. Clear? In the intensive phase as well as the continuation phase, you are going to use 1 adult tablet extra, that HRZT tablet. Clear? 1 adult tablet you are going to use extra. HRZT tablet in case of a intensive phase and HRE tablet in case of a continuation phase. If the child is 30 to 39 kilogram in weight, you are going to use 2 tablets, all right. At the same time, you have to add 2 extra adult tablets in intensive phase and continuation phase. Clear? 2 child tablets, child FDC combinations plus 2 adult tablets in intensive phase as well as the continuation phase. Clear? That's it. Similarly, you have streptomycin dosages also for children. So what are going to be the streptomycin dosages for children? Streptomycin dosage for children in 4 to 7 kilogram is going to be 0.1 gram, that is 100 milligram. In the next category, 8 to 11 kilogram is going to be 0.15 gram, 150 milligram. In the next category, 12 to 15 kilogram is 0.2 gram, that is 200 milligram. In the next category, 16 to 24 kilogram, that's going to be 0.3 gram or 300 milligram. In the 25 to 29 kilogram category, they are going to have 0.4 gram, that is 400 milligram. And in the 30 to 39 kilogram category, they are going to have a maximum dose of 500 milligram, that is 0.5 gram of streptomycin. This is the maximum dose that you can reach in children. In adults, it's 1 gram, exception age more than 50, maximum is 750 milligram. But here, it is 0.5, that is 500 milligram is the maximum dose that you can reach in children in the streptomycin. Clear? So how you are going to follow up? I told you follow up in the current guidelines is going to be both clinical as well as laboratory. So you have clinical follow-up and you have laboratory follow-up also. Clinical follow-up is done every single month. Very, very new addition, very important addition to the new guideline. And in the laboratory follow-up, you're going to do at the end of intensive phase, 2 follow-ups at the end of intensive phase, and you're going to do at the end of treatment, at the end of treatment, at the end of completion of treatment. That's what you're going to talk. So at the end of intensive phase, you'll be doing only a sputum smear, whereas at the end of treatment, you're going to do a sputum smear. At the same time, I have to send for a sputum culture also. Clear? So this is the idea. So this is very, very important to understand again. So this is something different from the previous guidelines also, but just know this is more than enough. At the end of intensive phase, just give for sputum smear. At the end of continuation phase, we are going to give for sputum smear as well as for culture. And remember, at any point of deterioration, plus along with that, at any deterioration in the patient, at anywhere if the patient deteriorates, develops new symptoms, develops after the completion of intensive phase, during the continuation phase, if they develop again fever, weight loss and all these things, it might be a failure case. So you have to do a additional sputum smear. At any point of deterioration, you can do an additional sputum smear and plus or minus a culture, which is optional. And one of the very important major change in the new guideline is going to be on the follow-up. So, and we are going to do follow-up for a long term. That is approximately for at least 2 years. In the sense, how frequently you do the follow-up in the next 2 years, even after the completion of treatment, it's once in 6 months, 6 monthly. That is, we'll be doing follow-up at the end of 6 months after treatment, then at the end of 12 months after treatment, then after 18 months after treatment, and finally 24 months or 2 years post-treatment. So 4 follow-ups is mandatory. This is a new addition, long-term follow-up in the current guidelines, previously which we are not doing. And now let us move on to the treatment outcomes. What are the treatment outcomes that you're going to have? So, and you have a lot of definitions like cured, successful treatment, lost to follow-up, regimen changed, and so many other definitions. So, let us see one by one what are the definitions. The first definition I'm going to call as cured. So, what do you mean by cured? Patient is initially at the beginning of the treatment, he or she was having a microbiologically confirmed tuberculosis, but at the end of treatment, after completion of treatment, patient is sputum or culture negative. Clear? Sputum and or culture negative. So this is what we defined as cure, or like patient is completely cured of the disease. Number two, we call treatment success. Remember, treatment success is not the same as that of the cure definition, where here the patient has completed treatment irrespective of the outcome. Completed treatment, which means he has completed the prescribed duration of antitubercular drugs irrespective of the cure status. Whether cured or not cured doesn't matter, patient has completed the prescribed duration of treatment. That's what we call as treatment success. It's for epidemiological indicator, for our own assessment purposes, how effective our social workers are interacting with the patients and making them continue the treatment and complete the treatment. So this is our own outcome assessment. So this is something different. Don't get confused. So this is called treatment success, but you have to know that this is not the same as that of the cured definition. Then failure to respond. So this definition is typically used only for pediatric TB patients where they don't develop any weight gain or they remain statically without any gain of weight with like years passing by. So this is what we call failure to respond, typically used only for pediatric TB cases, not in adult TB cases. Number 4, we have loss to follow. So what do you mean by loss to follow? Which means interruption in the regime, interruption in the antitubercular drugs at least for 1 month or more and consecutively. So this is what we refer to as loss to follow. I mean, if it's within 1 month, it will not be called as loss to follow. If it's interrupted, I mean, antitubercular drug therapy for at least 1 month or more, then only we'll call it as, and consecutively, not like 2 days in the first month, 10 days in the second month. No, like additionally, if you have this, interruption in the ATD, that will not be called as loss to follow. It's not cumulative, it's consecutive interruption of the antitubercular drug therapy for more than 1 month or more, then we call it as loss to follow. Then we have not evaluated, which means we don't know the treatment outcome. Treatment outcome is unknown. Treatment outcome is unknown. And finally, we have regimen changed. Regimen changed, which means we have shifted to a MDR and XDR regime. Shifted to MDR regime. So this is what we called as regimen changed. So these are the treatment outcomes that you have to know. Clear? I have told you 6 classic definitions: cured, then treatment success, then failure to respond, loss to follow, then not evaluated, and regimen changed. These are the 6 classic definitions for treatment outcomes in the current guidelines. Now we are moving on to the very big area called a drug-resistant tuberculosis. First, before knowing how to treat a drug-resistant tuberculosis, we have to know the definitions of different drug-resistant tuberculosis. Number 1, we have this monodrug resistance, we call it as MR. Then you have polydrug resistance, that's called a PDR. Then you have multi-drug resistance, that's called MDR. Then you have rifampicin resistance isolated, that's called RR. And you have extensive drug resistance, that's called a XDR. So these are the different categories of resistance are there. But remember, MDR and rifampicin resistance are like together because they will be treated in the same way. So there's no difference. You have to know that. Rifampicin resistance, since it's the most potent antitubercular drug, it will also be treated as a MDR TB only. So that point I'm telling before itself. Now what are the definitions? Monodrug resistance means resistance to any one first line ATT, any one first line antitubercular drug, but it should not be for rifampicin, but definitely not for rifampicin. Very important point. If it's rifampicin resistance means it will come under RR and it will be treated like MDR. So it's different. So it should not have rifampicin resistance, but any one first line antitubercular drug. So now I'll tell you multi-drug resistance, then you will understand why you have a polydrug resistance definition. Multi-drug resistant definition means you have resistance to H and R. Resistance is there, plus or minus other first line drugs, doesn't matter. first line ADs, plus or minus other first line ADs. But if you have H and R resistance together, that is the definition for a multi-drug resistant tuberculosis. Clear? What is polydrug resistant tuberculosis? Polydrug means resistance to more than one, not one, more than one first line antitubercular drugs, but definitely not for H and R together. You should not have resistance to H and R together. Clear? It should not have resistance to H and R together. So what do you mean by rifampicin resistance? Rifampicin resistance means you have resistance for rifampicin plus or minus other first line drugs, first line antitubercular drugs. Resistance to rifampicin plus or minus other first line drugs. But remember, there should not be any resistance for INH. Suppose if the patient has resistance for INH, it will be put under MDR-TB. So they can have resistance to rifampicin plus or minus other first line ADs, doesn't matter. Even if they have isolated rifampicin resistance, then also it will be called as rifampicin resistant and it will be treated like MDR only. But they might have resistance to other drugs also, but it should not be there for INH, because if there is resistance to rifampicin and INH together, it will be put under MDR-TB only. Similarly, I can add up a definition here. I told you in a polydrug resistance, more than one first line ADs will be resistant. But I told you definitely patient should not have H and R combination resistance, and patient should not have rifampicin resistance. Patient should not have rifampicin resistance also. Why? Because if the patient has rifampicin resistance and other first line ADs, it will come under rifampicin resistance. Clear? Or if the patient has rifampicin resistance and INH resistance for that matters, then it will come under MDR-TB. So, I mean, it's not confusing, but it's easy to treat. I mean, again, the treatment depends on this. That's why these definitions are important to understand. Extensive drug resistant tuberculosis, very easy, nothing to worry about it. So, you have resistance to rifampicin and isoniazid, all right, and you will have resistance to at least one fluoroquinolone. That's a very important second line drug, that's why. And you will have resistance to at least one injectable second line agent, that is capryomycin or kanamycin. So if it is the case, then definitely it is called as extensively drug resistant tuberculosis or XDR strains. So let us recap what all we have seen. Monodrug resistance, you have resistance to any one first line agent, but should not be there for rifampicin, because otherwise it will come under rifampicin resistance. Then what do you mean by your polydrug resistance? Polydrug resistance means more than one first line antitubercular drugs, but it should not include H and R together, which means it will come under multi-drug resistance, or it should not include rifampicin in that category, because if rifampicin is there along with other first line agents, also it will be called as rifampicin resistance only. Clear? So then third is multi-drug resistance. You have H and R together. We have this combination, it's multi-drug resistance irrespective of whether other first line drugs are working or not. Then you come to rifampicin resistance. Rifampicin resistance means any resistance to rifampicin plus or minus other first line antitubercular drugs, but it should not have INH, because if R and INH are resistant together, it will be called as MDR-TB. So that's why you have separate rifampicin resistance. And finally, XDR is an extensive drug resistant tuberculosis where you should have resistance for rifampicin, isoniazid plus or minus other first line agents, doesn't matter, plus at least one fluoroquinolone, plus at least one second line injectable drug, for example a capryomycin or a kanamycin. So if you have this is what we called as extensive drug resistant tuberculosis. Remember, in exams you will not be asked all the definitions. The most important definition you will be asked is in the MDR and the XDR. So please be very sure about this MDR and XDR. Clear? MDR, rifampicin and isoniazid irrespective of other first line drugs, doesn't matter. Rifampicin and isoniazid together, it is MDR, that's all. And extensive drug resistance, rifampicin and isoniazid plus at least one fluoroquinolone plus at least one second line injectable drug, irrespective of resistance to other drugs, doesn't matter. So this is what we refer to as XDR-TB. Remember, isolated rifampicin resistance or a category called rifampicin resistance will also be treated like a MDR and MDR-TB only. It will be followed by the same regime. And treatment, what will you give the treatment? Treatment is very simple. In a monodrug resistance, any one first line drug is resistant except rifampicin. So which means you can add rifampicin to these patients, which means there is no rifampicin resistance. I told you except rifampicin resistance in monodrug resistance. So you can add rifampicin here. Plus at the same time you can add other two sensitive drugs, sensitive first line drugs. first line antitubercular drugs, because I told you only monodrug resistance, which means only one drug is going to be resistant. Clear? Remaining out of 4 standard first line antitubercular drugs, so you can add other 2 antitubercular drugs along with rifampicin. For example, you have H, R, Z and D. Suppose if, let us assume, isoniazid is resistant, then you can add rifampicin plus you can add pyrazinamide and ethambutol. Or suppose if you have H, R, Z and D and you have ethambutol resistance, then you can add rifampicin plus H and Z. So depending on what resistance you encounter, based on that you can add the other drugs. How you're going to go about polydrug resistance? Polydrug resistance I'm going to treat with rifampicin definitely, because in polydrug resistance also it should not include rifampicin, because rifampicin, if it's resistant, either it will come under MDR if there is isoniazid resistance also, or it will be called as rifampicin resistance if you have no isoniazid resistance. Clear? And resistance of other drugs irrespective of that. So in this polydrug resistance, by definition, they should have rifampicin sensitivity. So you add rifampicin. Along with that, you add at least one sensitive first line drug, if it is there, plus at the same time you have to add one fluoroquinolone plus one injectable second line drug. Along with that, you have to add one group 4 agent, which I'll tell you what is group 4 agent, which means one of ethionamide, cycloserine or PAS. So we'll be doing this. Ethionamide, cycloserine or PAS. Any one drug you can add from these drugs. Clear? That's the idea. So you're going to add rifampicin along with one first line antitubercular drug plus one fluoroquinolone plus one second line injectable drug. Along with it, we'll be adding one group 4 drug, which I'll tell you in some time, which includes ethionamide, cycloserine or PAS. Now, how you're going to treat these 3 things: multi-drug resistant, rifampicin resistance, or extensive drug resistance. Remember, if you take the TB guidelines in India, they will give a standard guideline for how to treat rifampicin resistance, how to treat a MDR and how to treat an XDR. But to be honest, the guidelines that have been given in Indian guidelines, in the TB, guidelines that are released by Government of India, is based on some standard basic concrete understanding of how to construct a regime. So that's why I'm going to teach you how you're going to construct a regime rather than just mere mugging up of these drugs that has been used in first line, second line, intensive phase, continuous phase. First, let us understand how you're going to construct a regime, and then if you study the guidelines, it will be so simple. So first, let us see what WHO has told in 2011 and how to categorize these drugs and how they categorize the drugs for drug-resistant TB in 2016. There was some changes, like they put group 1 drugs. These are first line oral drugs, which include the famous HR, ZT, oral first line drugs, HR, Z and E. Then they put as group 2, these are injectable drugs. In the first line, we had streptomycin as an injectable agent, and in the second line DDT, we had amikacin, even though we don't use very commonly now, kanamycin and capreomycin. Clear? So these are the second line injectable agents. So this will come under group 2. So group 3, it will come under fluoroquinolones. So they put fluoroquinolones under group 3, where they've included levofloxacin, moxifloxacin, gatifloxacin and ofloxacin. But ofloxacin has been removed in the current guidelines. We don't have any use of ofloxacin anymore. Then we have group 4 agents, which are nothing but other oral bacteriostatic agents. Other oral bacteriostatic agents, which typically included ethionamide, cycloserine and PAS. Remember cycloserine, if you remember, I had told it is a bactericidal drug in the previous pharmacology video, but it depends. In this particular table, they are put under bacteriostatic, but again, I told you there itself, the bactericidal static activity depends on the susceptibility of the strains. That's too much for you, but remember, it can be static or cidal depending on the situation. But in this guideline, it's put under static, that's all. But generally, many books will give it cidal also. It's both bacteriostatic or bactericidal depending on the susceptibility. And finally, you have group 5 drugs, where you have ATTs, that are antitubercular drugs with limited efficacy. Limited efficacy or marginal efficacy, we don't know. So where we had linezolid, then we had clofazimine, Then thioacetazone, very, very poor ATT. Nowadays, we don't use thioacetazone for any reason, unless and until there is no other choice. Then high dose of INH macrolide called clarithromycin, which we have discussed already, all these things. Then imipenem with clavulanic acid combination, meropenem alone, amoxicillin clavulanic acid combination. Clear? And the newer ones were not there that time, that is bedaquiline delamanid. So we cannot put under group 5. So these are the drugs classification that was given by WHO in 2011. This was very cumbersome, and this is not useful for drug resistant TB. Later on, they understood that this is very cumbersome to use for drug resistant TB, so we wanted to make it a little bit more easier. So how to make it more easier? Let us put a different classification, where in 2016 they made a group A, and this is what you have to remember. 2016 group A. Group A are nothing but fluoroquinolones, and this is exclusively set up for drug resistant TB only. How to construct the regime for drug resistant TB? Group A will be fluoroquinolones. For example, you have 3 drugs currently: Levoflox, Moxiflox, and Gatiflox, of which Levoflox is the one which is going to be commonly used. Clear? Ofloxacin has been removed. I told you this is not going to work, ofloxacin, currently. We have discussed this multiple times. And group B is second line injectable drugs. We have 2 drugs currently. One is kanamycin and second is capreomycin, and amikacin is going to be only optional in the current guidelines. Is not a very important drug. And group C, we have core second line agents. They have removed the term bacteriostatic cycle and all these things. They have just put core second line agents. So what are the other core second line agents apart from fluoroquinolones and SLIDs? Like the same, I can use ethionamide, cycloserine, and they have done 2 important things. What they have done is, based on the research and quality of trial data, so they have upgraded clofazimine and they have upgraded linezolid, which means linezolid and clofazimine are no longer drugs with limited efficacy in tuberculosis. They have upgraded to core second line agents. That is, your linezolid is going to come here and clofazimine is going to come here. Clear? They have been upgraded in the current guidelines to core second line agents. In the previous guidelines, it was only limited efficacy. But based on the trial results and based on the research evidences, we now know these are some agents which have very good efficacy as of now. Then we have group D agents. In the group D, we have D1, D2, and D3. D1 drugs are nothing but other drugs that are going to be sensitive, may be sensitive in an MDR TB, like except H and R. You can put pyrazinamide, ethambutol, or high dose INH, probably high dose INH. Remember, one important thing you can see, again they have upgraded the high dose INH to group D1. Rather than agents with limited efficacy or unproven efficacy, they have put high dose INH in D1, which is still effective according to the new guidelines. So pyrazinamide, ethambutol, or high dose INH. Low dose INH and rifampicin will definitely be resistant. And D2 are the newer drugs with good efficacy, that is bedaquiline and delamanid. And D3, these are the drugs with limited efficacy, again, limited data. Very important point is the fact that PAS has been downgraded. You can see PAS was previously a very important group 4 agent. Now it's been downgraded to agents with limited efficacy. Then thiostazone, we know that always it's going to be one of the agents with limited efficacy only. Then amoxicillin clavulanic acid, still limited efficacy. Imipenem clavulanate or meropenem, still limited efficacy only. So a lot of drugs will come under this agents with unknown or limited efficacy. So these are the groups that you have to follow. Remember, group A is fluoroquinolones, group B is second line injectable agents, and group C is core second line agents, where your linezolid and clofazimine has been upgraded in the recent guidelines, and it also includes your ethionamide and cycloserine. And group D, you can have D1, D2, and D3. D1 are the other first line drugs, oral drugs, except streptomycin, that is your pyrazinamide, ethambutol, and probably high dose INH. High dose INH has been upgraded now to D1 from limited efficacy. And D2 drugs, we have newer ones like bedaquiline and delaminate, there is a lot of possibility they might be upgraded to group 1 or group 2 also in the future, because they are supposed to be extremely effective. The cost factor is the current problem with bedaquiline and delaminate. Apart from that, currently the efficacy, and many researchers are showing that it's having excellent efficacy. Okay, group D2, newer drugs. And group D3, these are agents with limited efficacy, whereas PAS has been downgraded in this from the previous guidelines. So PAS, thiazolone, and we're going to have amoxicillin clavulanic acid and imipenem, clavulanate, and meropenem. So these are the drugs that come under D3. So how you're going to construct a regime? So this is very cool actually. So now if you understand this, it's very easy to construct a regime. All you need is a combination of 5 sensitive drugs minimum. If you add up these, I'll tell you how to add up the drugs, but you should need at least minimum of 5 to 6 drugs, or WHO tells around 4 to 6 drugs, but you need a minimum of 5 sensitive drugs. That's what we need. So how we are going to add about? So let us see in the old 2011 guidelines where they told you're going to add at least 1 to 2 drugs from group 1, that is either of these 4 drugs, whatever is sensitive, you're going to add 1 to 2 drugs in a drug resistant TB. And next, in the group 2, injectable drugs, we are going to add at least 1 drug. 1 is enough, but at least 1. And group 3 fluoroquinolones, again, at least 1 drug. Clear? But 1 is enough. But at least 1 drug, again. In the group 4, they told 2 drugs can be added, whichever is sensitive. Clear? So remember, it's not a mandatory that you should add 1 drug. But minimum there should be 1 drug. There's a lot of difference between that, but it's not mandatory. Suppose what if you do if all the drugs are resistant? If entire this injectable group is resistant, which means this 1 cannot be added. But idea is sensitive drugs, adding at least 1 sensitive drugs if it is sensitive. If it is not sensitive, you cannot add. So if you add sensitive drugs from 1 to 2 from group 1 if it is sensitive, 1 drug from injectable drugs if they are sensitive, and 1 drug from fluoroquinolones minimum if they are sensitive, and finally 2 drugs from the bacteriostatic oral group, that's group 4, if they are sensitive. And if you add up, it should come up to 5 total at least. Minimum, this is a minimum requirement, 5 should come. But if it's not going to add up to 5, if the drugs, sensitive drugs list is not adding up to 5, which means what I'm trying to tell is, if there is so much of resistance, which means let us assume this entire group is resistant, this entire group is resistant fluoroquinolone, and in this only 1 is sensitive, and here only Z is sensitive, remaining all are resistant, let us assume. So in this drug, in this particular patient, you can see only 1 drug is available from group 1, only 1 drug is available from group 4, so which means it's adding up only to 2 drugs, only 2 sensitive drugs. So this is not a right combination, isn't it? So in this condition, what you have to do is, you have to pick up drugs from group 5, add drugs from group 5, and make a combination of 5 drugs. That's all. So idea is very simple. 1 to 2 group 1 drugs, at least 1 fluoroquinolone, group 3, at least 1 injectable drug, that is group 2, and at least 2 drugs if they are sensitive from group 4. So combination should come up to 5 at least. If it's not adding up to 5, if there is extensive resistance, then you can pick up drugs from group 5 if they are sensitive again. So finally, you try to make a combination of minimum of 5 drugs. That's it. This is the old regime. But let us come to the new regime. It's just a tinkered regime from the 2011. Since the classification has changed, we have just tinkered it, but not it has not changed that much. For example, you will add at least 1 drug from group A, provided if they are sensitive. Very important point again. It's not like if all are resistant, still you will add a fluoroquinolone. If they are sensitive, you will be adding 1 fluoroquinolone. Then we'll be adding 1 second line injectable drug, that is from group B, at least 1, again if they are sensitive, and 1 to 2 drugs from group C if they are sensitive again. Any one of from linezolid, clofazimine, ethionamide, and cycloserine. Remember, this linezolid and clofazimine has been now upgraded to group C here, which means they are now effective drugs according to WHO. In the previous guidelines, we know these drugs are doubtful efficacy, linezolid and clofazimine. Now they have become efficacious drugs in the recent classification. So 1 to 2 drugs, if they are sensitive, you can add from this group. Similarly, from group D, and especially this D1 group, you can add another 1 to 2 drugs. So that whatever you add, a total combination should come up to 5 For example, 1 from here, 1 from here, 1 to 2 from here, 1 to 2 from here. So which means the total combination at least should come up to 5 minimum. That means sensitive drug list should come up to 5 minimum. Suppose if it's not adding up to 5, which means the sensitive drug list that you're adding in this drug resistant regime is not coming up to 5. Same thing, you're going to take drugs from group D2 and group D3, which means in this condition you can add drugs from group D2 or group D3. According to RNTCP, group D2 bedaquiline is preferred for this purpose. Group D2 bedaquiline is preferred for this purpose. Clear? Then one more small glitch is there here, and again you need a bedaquiline in some other area also. And what is that particular point is the fact that suppose if you are adding up all the drugs, even if the sensitive drugs are adding up to 5 from group A, B, C and D1, if they're adding up to 5, but if you cannot use either group A or group B drugs, suppose if you cannot use at all, then in that condition also you should have bedaquiline. So let me tell you with an example. For example, let me assume that fluoroquinolones cannot be used at all due to some reason, either due to toxicity or due to some other QT prolongation issue, because sometimes, if you add bedaquiline, you cannot add a fluoroquinolone. Clear? So for some reason, you are not able to use a fluoroquinolone, or if the entire fluoroquinolone spectrum is resistant, it's an extremely resistant bacteria. In those conditions, you are adding one drug, let us assume, from second-line injectable drugs, you are adding 2 drugs from this group C agents, that is ethionamide, cyclosinidazole and clofazimine, and you are adding 2 drugs from the first-line oral drugs also, that is from pyrazimide, ethambutol and high-dose INH. You are adding 2 drugs, all right. But now you are getting a combination of 5, isn't it? So 1 plus 2, 3, 3 plus 2, 5. 5 sensitive drugs. You've got a combination. But the problem is you don't have a very important group in this particular regime, that's a fluoroquinolone. Suppose if you're not having a fluoroquinolone in this group, still if the sensitive drug combination comes up to 5, still it becomes an indication for adding bedaquiline. Similarly, one more entity, like if you cannot use group B, which means if you cannot use any second line injectable drug, still you have to add bedaquiline. Let me show you an example. For example, one drug, fluoroquinolone, you have added, but this group you cannot add because of some problem like entire resistance to second line injectable drugs, or patient doesn't want injection, or some other reason is there, you cannot add second line injectable drug in this group. So you are getting 2 drugs from this group. Let us assume it is sensitive, and you're getting 2 drugs from this group also. Let us assume it is sensitive. Now you know very well it is adding up to 5. 2 plus 2 plus 1, it is 5. But you cannot be satisfied with that. Why? Because I told you this is a very important group, second injectable drug, and you cannot add entirely. So if you cannot use any one of fluoroquinolone, or if you cannot use any one of second line injectable agents, at least minimum, even if the combination adds up to 5, still you have to add bedaquiline. Clear? So these are the 2 indications for bedaquiline. One, if your regime doesn't add up to 5, if you're adding A, B, C, D1, and if your sensitive drug total and tally is not equal to 5, you can add bedaquiline as a preferred entity. But you can add other drugs also if still your combination is not coming up to 5, but preferably bedaquiline can be added. Second indication for bedaquiline is the fact that if your regimen will not contain either a fluoroquinolone or a second line injectable drug, which means you are adding up to 5, but still your regimen doesn't contain an entire fluoroquinolone group, cannot be added. Or if your regimen doesn't contain a SLID at all, second line injectable drug at all, that also becomes an indication for adding bedaquiline to your regime. So these are 2 standard indications for bedaquiline as of now, according to the RNTCP. It's little difficult to comprehend in the initial setting. When you listen to me for the first time, it might be difficult, but when you listen to my words subsequently, you will be getting what to be done. Okay, so it's quite simple. It's not that difficult. Now let us go on to the duration of treatment. Duration, and again, depends. Usually the intensive phase typically is given for 6 to 9 months, and the continuation phase will be given for 18 months. That's the standard duration. And how will you go about to the continuation phase? Remember, continuation phase, usually you will avoid the second line injectable drugs, which means in fact you will avoid all the injectables for that matters when you move on to the continuation phase, and you will avoid only one oral drug, that is pyrazinamide, which means in the continuation phase, all the oral drugs of intensive phase will be given. All the oral drugs of intensive phase is transferred to the continuation phase except pyrazinamide. Pyrazinamide generally is not used in the continuation phase also because of high risk of hepatotoxicity and other complications. So all other oral drugs of intensive phase can be carried along to the continuation phase and you should continue those drugs. At the same time, your second line injectable drugs should be avoided, which means you should not use injectables during the continuation phase usually. But make sure, I told you minimum 5 drugs, 5 minimum in the intensive phase, I told you already. But similarly, you have to use at least 4 drugs minimum in the continuation phase. There's one small problem in that. Suppose if you are using 5 drugs, let us assume, this is a small example I'm giving. Suppose 5 drugs you are using in the intensive phase, that is in that which includes drug A, B, C, but it includes, clear, a Z from D1. So from D1, it includes Z, and you can, from, let us assume, this is an example I'm telling you, from group C you are using 2 drugs, and from group A you are using 1 drug, and group B you are using 1 drug. Clear, this is your regime. Let us assume this is your regime. If your D1 group is having only 1 drug, that is pyrazinamide as an agent. So now what you will be doing, you will be avoiding when you are carrying away to the continuation phase. Once you complete the intensive phase, you will be trying to avoid this Z, and you will be trying to avoid this group B, that is second line injectable agent. So you will be giving group A drug plus 2 group C drugs. Let us assume. So now your combination is coming only up to 3 drugs. But what I told you have to use 4 drugs minimum. So what you will be trying to do? You will be trying to take drugs from D2 or D3, which means you will be trying to add drugs from D2 or D3. D2 means it's bedaquiline, typically in India, or you can take from D3, that is this clavulanic acid, amoxicillin combination, meropenem, imipenem, clavulanate, thiostazone. You'll be trying to add something from D3, and this should be strictly avoided and should not be done. That brings us to one very important rule. Whatever you use in intensive phase only should be carried out to the continuation phase. A new drug should never be added in the continuation phase. Never add a new drug to the continuation phase. Never add a new drug to the continuation phase. Very, very, very important point. So in this condition, what you will be doing? Suppose let us assume, if you are having only 5 drugs and you are in a scenario that carrying on to the continuation phase will not have 5 drugs and you'll have only 3 drugs in this scenario, don't take it 5 in the intensive phase and make it 6 so that you can take 4 drugs in the continuation phase, which means in the initiation, in the intensive phase itself, in the beginning itself, add drugs from D2 or D3. Very simple. So what I will be doing in this example, so I can add 1 drug from group A and I'm adding 1 drug, that is second line injectable drug from group B, and let us assume I'm having 2 group C drugs, so it's adding up to 4, and I'm having only 1 group D drug, D1 drug, that is pyrazinamide in this example. So now you know that when you remove this group B drug during continuation phase and when you remove this pyrazinamide during the continuation phase, I'll be ending up only with 3 drugs. So now itself, in the beginning itself, make it a combination of 6, that is add a drug from a D2 or D3. For example, I'll be adding either a bedaquiline to make it 6, or I'll be adding some D3 drug like amoxicillin, clavulanic acid, or thiostazone, or meropenem, or imipenem. So any 1 drug I'll be adding from group D3. Very, very simple. Clear? So that now if I parry over this to the continuation phase, I'll be just adding 1 A drug. I cannot add B because it's injectable. I can add the same 2 C drugs, plus I cannot add D1 because it's pyrazinamide only is there in this example. So I'll be taking D2 drug. In this example, I'll be carrying over bedaquiline, which means still I'm ending up with 4 drugs. That is the least minimum. At the same time, I'm making sure I'm not adding any new drug for the first time in the continuation phase. So this is all about the mind games, and it's all about how much you understand the regime. No, like that's all. So it's just simple. You have to follow the rules. That's all. Clear? It's the rules of a game. It's like that. So just use a little bit of orientation and understanding. As simple as that. So this is how you form a regime. So forming a regime in MDR is so easy. That's all, provided if you understand the stuff. So let me give you a second example. Suppose if you are having 1 group A drug that is sensitive and 1 group B drug that is sensitive, that is second injectable you are adding, and 1 group C drug is sensitive, and let us assume in this example 1 group D drug is sensitive. which means in this example, let us assume only ethambutol is sensitive. Clear? In the D1 group. But it's coming up in the intensive phase, it's not adding up to 5. So I have to add one more drug from D2 or D3, preferably D2, or I can add from D3 also. So I'll be adding one more drug. So that what I'll be continuing in the continuation phase is 1A from 1-fluoroquinolone. So B cannot be used in the continuation phase. So I cannot use B. So that same C drug, which is 1, I can continue. At the same time, 1 D1 drug, I can continue. Clear? That is ethambutol. At the same time, I can continue either 1 D2 or D3 drug. Preferably, I'll be using bedaquiline for this purpose. So now what I'm doing is I'm using 5 drugs minimum in the intensive phase and at least 4 drugs in the continuation phase. I'm making sure there is no new drug added to the continuation phase for the first time. Okay. Now let us take another example where the patient is sensitive only to drug A, group class A. One drug has been added in that, but let us assume you cannot use a second line injectable drug, which means they are either resistant or for some other reason, for example, nephrotoxicity, you are not using your aminoglycosides. For some reason, you are not able to use the second injectable drugs. So now let us assume only one drug in group C can be used, but you can use 2 drugs from group D, that is ethambutol and pyrazinamide. So now you know that you are ending up with 4 combination, but I'll be using one drug from D2 and probably I can add a D3 also. D2 I'll be still using bedaquiline. That is one drug is there. So now a combination of 5 is there. I know that. So now I'll be pairing over. So what I'll be doing is 1 from A I'll be adding and 1 from C I'll be adding, and D1 group I have 2 drugs, but I cannot use pyrazinamide, so I'll be using only ethambutol. At the same time, from D2 I'll be adding bedaquiline, or if bedaquiline is not available, then you can add a D3 drug. So now you can see 1, 1, 1, 1. So 4 drugs in the intensive phase, and I can use 5 drugs in the continuation phase. Sorry, 5 drugs in the intensive phase and 4 drugs in the continuation phase. And I'm making sure that I am not adding any new drug in the continuation phase as well. So very simple to form a regime. So this is how you form a regime. So it is something depends on the sensitivity pattern also. So which means a drug which is not sensitive cannot be added. How can you add if the culture report shows resistant? And if all the fluoroquinolones are resistant, it's not a rule that you should have 1 fluoroquinolone for sure. If it's sensitive, you add 1 fluoroquinolone at least. That's the idea. And again, what will be the total duration of treatment? Total duration of treatment depends on whether intensive phase is stable or not. The problem is intensive phase itself is not stable. Remember, the 6 to 9 months rule will be applicable only if you can add a fluoroquinolone plus second line injectable drug to your regime. If your second line injectable drug and fluoroquinolone both are there in your regime, then only your intensive phase will be for 6 to 9 months. Suppose if there is another scenario where fluoroquinolone or second line injectable drug cannot be used, in this case, your intensive phase can be prolonged up to 3 months. So your intensive phase now will become 6 to 12 months. Suppose if you cannot use either a fluoroquinolone or second line injectable drug or both due to some reason, in that condition you have to extend the intensive phase by 3 months. So total duration, intensive phase duration may be up to 6 to 12 months. So total duration again will be variable. So total duration may be 24 to 27 months in case if fluoroquinolone and second line injectable drug is used, both are used. So total duration may become 24 to 30 months in case if your fluoroquinolone or second line injectable drug or both cannot be used. In this condition, you can prolong. There is an amenity to prolong the intensive phase by 3 months at least. Okay. After this, we have to finally find a variation in this total duration of treatment. One variant is there. Variant of total duration of treatment, that is called short course MDR. That's called the short course multi-drug resistant treatment or a short course drug resistant TB treatment, also referred to as Bangladeshi regime, where WHO officials first tried this as a trial basis and on field study in Bangladesh. That's why it's called the Bangladesh regime, where in short course regime, I'll be actually using a total duration of only 9 to 12 months, nothing more, only 9 to 12 months total duration. Remember, this 9 to 12 months total duration is supposed to be as effective. They have proved that supposed to be as effective as your longer treatment like 24 to 30 months or 24 to 27 months. So just 9 to 12 months is enough. That's what they're telling. But the problem is one small glitch is there again. You have to know that this is applicable only if the patients are not exposed to antitubercular drugs in the past. If the patient has been exposed to antitubercular drugs in the past means, and they are coming with MDR after that means, you cannot use this short course regime. In that you have to go for the traditional regime only. But as of now, the status of this short course MDR is not approved in India, but very well endorsed by WHO. Clear, but right now in India, it is not yet applicable by RNTCP, but WHO clearly have endorsed the short course multi-drug resistant treatment or drug resistant TB treatment, where you are going to give only a total duration of 9 to 12 months rather than 24 to 27 or 27 to 30 months. But this is applicable only in patients who have not been exposed to antitubercular drugs in the past, or we have not taken the ADDs in the past. By definition, a new case only can be given, or a new fresh drug resistant TB only can be used with short course MDR regime. So with this, we can complete this particular topic. And in the next section, the last portion of the treatment aspects of tuberculosis, we'll be discussing on the special cases like HIV TB co-infection, pregnancy TB, heterotoxicity and TB, kidney disease and TB, and latent TB infection, how to treat all these things we'll be discussing in the next section. Thank you.